Welcome to the third installment of Primary Care Matters. I'm Sue Bornstein. I'm the Executive Director of the Texas Medical Home Initiative and co-lead of the Texas Primary Care Consortium. The Primary Care Consortium is the only statewide collaborative with a mission to advance high-quality primary care for Texans. It's co-led by the Texas Health Institute, which is Texas's designated public health institute, and the Texas Medical Home Initiative. The purpose is to take a deep dive into topics that impact the provision of high-quality primary care in Texas and beyond. In this program, we'll explore the state of the public's trust in the healthcare system and in public health institutions. We'll look at the role that the internet and social media play in how our patients make decisions about their own healthcare, specifically with a focus on vaccines. We'll also discuss how scientists and clinicians really can do a better job communicating complex and sometimes rapidly evolving recommendations with patients. We'll talk about how we can apply new communication strategies to encourage vaccine hesitant and vaccine resistant patients to become vaccinated. This discussion is timely as we're seeing the resurgence of measles in the United States. So we also know that vaccine uptake is a reliable marker for trust in physicians. The higher the trust, the higher vaccination rates. And plain and simple, vaccines prevent disease and save lives. I am thrilled to welcome Dr. Janet Jokela, internal medicine physician and infectious disease specialist and public health expert. Dr. Jokela is Senior Associate Dean for Engagement at the Carle, Illinois College of Medicine in Champaign, Urbana, Illinois, and is a clinical professor there. Janet has written and lectured on restoring trust in medicine and public health. Dr. Jokela, welcome. Please tell us a little bit about yourself and how you chose the specialties of internal medicine and infectious diseases.
Thank you so much, Sue. It's a pleasure to be here with you and all of your colleagues in Texas and everywhere, and it's really a delight to be here. So thank you so much for the invitation. I tell you, that goes back a ways to be thinking about, those decisions about internal medicine and infectious diseases and all of that. It takes me back, but it's all a good thing. For what it's worth, I'm a first-generation physician. Okay, there is no one in my immediate family or even extended family who is a physician, and I think that all started actually when I was an exchange student in Sweden after high school. My host Swedish grandfather was a physician, and I found him to be very kind and patient, certainly patient with me and my poor Swedish at that time, and but also inspiring. And it got me thinking about, maybe medicine would be a good career path. So at any rate, later on, fast forward, a few years, then I was in medical school and listening in the lecture hall to our microbiology professor. I just adored him. He was this older guy and he told these clinical stories of things like his positive PPD and his Pneumovax vaccine and I don't know what all, but things like that. And I just found it to be really inspiring. And then I started to think, well, how can I do infectious diseases without doing internal medicine or pediatrics first? And of course, as we all know in medical training here in the US, that's not an option. So at any rate, going through the different clinical rotations, I really gravitated towards internal medicine. I just really liked it. I like the comprehensive care that internal medicine physicians provided to their patients. I love the opportunity for longitudinal relationship building with patients. And I also like the possibility of going on to subspecialize later if, that was the career path to pursue. So given all that, I ended up matching in internal medicine. I went to Boston City Hospital for my residency. I absolutely loved it. And in fact, I love general internal medicine more than I expected to. So, excuse me. At any rate, I've always had this love for general internal medicine and primary care, as well as the specialty of infectious diseases. After residency, I ended up pursuing a fellowship in infectious diseases And I've had my foot in both areas for ever since, for the years since. So it's been a wonderful journey, and I'm just so grateful to have had the opportunity.
Thank you, Janet. Well, the decline of trust in healthcare is not new. And we have to look not much farther than really the shameful legacy of the Tuskegee experiment. That persists to this day, and that was 53 years ago after it was made public. Um, Fast forward a bit into the 1990s. So, not all of this is scientific, but the 1990s saw the advent of managed care and shortened office visits and its associated gatekeeping, which no one liked. And that really put barriers between patients and their clinicians. Um, and I have to say that, in my opinion, the erosion of the patient-physician relationship really has been fueled in part by the widespread use of electronic health records. And we know that they have a good purpose. But I will say that we all hear stories, and maybe we've had our own stories of listening to a person talk about their experience with their clinician, where the clinician was staring at the screen and not looking at them and not interacting with them, and that is certainly not ideal. We also are plagued by what Tom Bodenheimer, the great researcher, calls the tyranny of the 15-minute visit. The people that we take care of, many are complex. They have multiple comorbidities. They're on multiple medications. They sometimes have complex psychosocial needs. 15 minutes simply is not enough. And so the net result is primary care shortages create long waiting times to get in to see a primary care clinician. And then when you're there, short FaceTime. And also many people, and we've all heard these thoughts, have questioned the financial motives of clinicians, including the perception that doctors can be unduly influenced and rewarded by pharmaceutical companies. Now, I think historically that probably has been more of an issue than it is now. There certainly are many more safeguards in place now, and that's a good thing. But recent social media posts, you've seen them, suggest that one of the reasons that pediatricians in particular push vaccines is because they're profitable. And spoiler alert, they're not. And so we'll talk more about that later. Further, the damage that was done by Andrew Wakefield, Dr. Wakefield's discredited study that claimed a link between the measles, mumps, rubella vaccine and the development of autism spectrum disorders. The damage cannot be overstated. The paper was retracted, it was discredited. He lost his medical license, but unfortunately, the damage to the public was already done. So in March of last year, Tom Nichols, who's an American writer, wrote a piece in The Atlantic called When Experts Fail. Tom wrote another book called The Death of Expertise, which I would recommend to anyone. It really helps lay the groundwork for kind of why we're in part in the situation we're in now. And he wrote in his piece, the coronavirus pandemic proved the perfect crucible for accelerating the decline of faith in experts. The pandemic struck at multiple political and cultural weaknesses within the edifice of American life. He goes on to say the public wanted clear and unambiguous answers that scientists could not give them. Yes or no, safe or unsafe, on or off. Many Americans, even those who wanted to be cooperative, just gave up. So it's clear that the COVID pandemic has shown a bright light on the limits, really, of our ability to communicate uncertainty in a way that engendered confidence in our patients and in the public. So, Janet, please respond to what I just shared about the erosion of trust and how and also the challenges of messaging in times of uncertainty. How can we do better in the future?
Oh, Sue, that's such a lovely summary. It's a painful summary, but so accurate. You hit on all these really important points and things that have really built up over time to bring us to the place where we are today. I tell you, it's a complicated problem and a complex problem, and there's a lot of people these days, I think a lot of experts, if you will, but people who are living in this space day in and day out who are really thinking about this, like, how do we navigate through this, and how can we best help our patients, and how can we best help the country, really, the population as a whole as we navigate through this. One thing that I'm reminded of a little bit with some of your comments and, thinking about this is going back to medical school and being a first generation student, all right? For some reason, I think I had, certain expectations or a certain view of what I thought medical school and medicine would be like, and I didn't know. But I had thought going into medical school, and of course, I didn't realize I had these expectations until I was there. But I think I had thought that medicine would be very black and white. Like say you have this problem and then you do this. And then, or if this happens, then you treat it with that. And what I learned in the course of medical school was medicine was not that way. Medicine is not black and white. There's a lot of gray. Well, and not gray, maybe a lot of different colors, but it's not binary. You do this, you do that. And that came as I mean, I was a naive medical student. What can you say? Um, that came as a bit of a surprise to me, but I can't help but think a lot of what we're hearing from the public, like, oh, they did such a bad job communicating during the pandemic, and we all know things that could have been better. The different messaging and all those, whatever all was going on at the time, it could have been handled better. It just reminds me so much of how I felt when I was first introduced to medicine at that level, that I was disappointed too. And it took me some time. I mean, it took me some years to kind of get used to the thinking and the approach to clinical problems and all of that. So at any rate, I think it's just not easy. I mean, even for people in medicine and medical school and training, as we go through, we come to appreciate that as we go through it, but it may not be inherently obvious early on. I will say too, another thing that I was struck with, again, going back to medical school, was at that time when I was there, which was in the mid 80s, was the whole HIV thing at that time, the HIV AIDS. And I tell you, that was another really important thing that was going on in society that motivated me to go into internal medicine and infectious diseases. I mean, my heart just broke for these people who were having trouble or challenges getting medications or access to care or whatever it was. And I thought, no, I mean, it's biology, it's an infection that they have and they need treatment, period. So, at any rate, how do we navigate this? I think that way forward will become more and more clear as certainly as time goes on and as we continue to think about it. I do think it's really important to communicate, whether we're one-on-one with our patient in the exam room or if we have opportunities at a broader level. So whether it's in a podcast like this or on the radio or wherever, but if we don't know the answer to whatever the question is being asked, is to say so. And also to say something like, this is what we know as of now. We may learn something differently tomorrow, and that will change what we do. And I think that piece was the piece that was missing early on in the pandemic. And unfortunately, there were terrible repercussions, as we know, and really challenging situations as a result of that. I think we're all still reeling from the pandemic, whether it's patients, clinicians, physicians, nurses, all of us. I think we're still really grappling with that whole horrific situation.
I think that's very, very well said. And thank you for sharing your reflections and your experience. And so you've alluded to this, we both alluded to this. It is no secret that we are living in a highly polarized society and in a world that's increasingly reliant on the internet for all kinds of information. And I will tell you that there is an emerging school of thought, and it's led by one of my mentors, Megan Ranney, and her colleague, Kristen Pantagani from the Yale School of Public Health. And they believe that we need to recognize that even the use of the term misinformation can be polarizing and depends on the audience. Now, as clinicians, we can maybe use that more freely, but it sort of tells people what corner to go to a lot of times, right? There are similar concerns about our characterizing people who, quote, do their own research in a negative way. And I've thought about this a lot, and I thought, last year I had a skin cancer on my hand. And so the doctor said, well, the skin cancers, that particular type on the hand, need to have Mohs surgery. Okay. So, okay, she tells me a little bit. So I'm like, I do my own research, right? So I'm one of those people. I think we all are, right? I think it's a natural instinct to, so I want to learn more about that. I want to understand. Now, I think then you get into a whole discussion about sources and the reliability, et cetera, et cetera. But my eyes have been opened in a different way about using terms like this when now I think of it myself. So, but again, one of the reasons that people look for information online, and we know this, the U.S. health system has not done a very good job communicating. It's typically top down, professional associations, and government agencies. What do? They publish papers, right? They publish papers and they look at evidence and they share recommendations on their websites. And that's important. And by no means am I saying that's not important. It's very important. That's how we advance knowledge, right? But what we do with that knowledge, I think, is the next step. And so this top-down sort of among ourselves approach is inadequate in a world of rapidly evolving information. And most clinicians, I certainly didn't have any training in formal communication, and I bet you didn't either. Most clinicians and scientists really receive little or no formal training in public communication. Now, I think the person in the exam room, as you talked about, I think that's different. I think that's a different set of skills in some ways. But how we communicate with the public, I have had no training in it. I thought this was an interesting statistic. More than half of Americans who reported trying new health tools or approaches in the previous year indicated that social media posts were the source of those strategies. So more than half. Only a third of those people learned about them from their doctor. Again, I think this just, whether we like it or not, whether this is reality, this is the world that we live in. And I will give you a little further evidence, and that is the family medicine physician and YouTube star, Dr. Mike, who's a family doc in New York, has 14 million YouTube subscribers to his channel. And so this is where people are getting information. He's a very reliable and relatable source. But the point of talking about this is that is the world we live in. And so what can we do? What can we learn from what can we as clinicians and public health experts? And we haven't really even talked, you have a master's in public health and a background. We haven't really talked so much about the public health, but how can we do better communicating, learning from these people like Dr. Mike and others who really have broken through on social media and they're sharing reliable, accessible health advice. What can we learn from that?
Oh, Sue, there's so much packed in there. Thanks for asking the question. And it's really important. I think this is one of the pressing questions for all of us today in medicine, public health, and science for that matter. How can we do a better job communicating and also connecting with the public? Certainly, there are some people who are exceedingly good at this. And I think we can all learn by observing what they do and thinking about how they approach it and everything else. I do think more is needed, though. And I love that article that Megan Ranney and her colleagues recently wrote, which appeared in the New England Journal. I think it is so spot on. The old way or current way, if you will, of communicating medical information and current research findings and all of that is outdated. It's important, it's critically important, and it serves an incredibly important purpose. at the same time, it's not reaching the people and the broader public, if you will, in a way that would probably be helpful for the broader public. And so the question is, how do we best do that? How do we best change how we communicate to do that? If Megan Ranney were to start a course, and I think they are starting a course for their medical students, and I'm not sure who else at Yale, it's like, I want to take it. Like, sign me up. I'd like to go. Um, I think we'll need more of that and probably more kind of training opportunities and educational opportunities for all of us in medicine and public health and science, like how to best communicate whatever nuggets of, you know, research results or other important messages that need to get out. I think that will be important for us because you're right. Those of us who've either been in practice for a long time or who are wherever, mid-career, or wherever they are, wherever we are, we haven't received formal training in that. And we certainly saw during the pandemic how important that will be. For those of us who have known Dr. Fauci, for instance, for a long time, and I had crossed paths with him years ago during my infectious disease fellowship, and he's co-authored one of our, major textbooks in internal medicine, Harrison's Textbook of Internal Medicine. At any rate, he did a really wonderful job during the HIV pandemic in terms of really helping to shepherd a lot of the research and the approach to research for HIV drugs and trials and all that through the NIH, and that was critically important at that time. And he did a wonderful job communicating, I think, with that community and all of us and all of that. So I think it came as a bit of a uh, for lack of a better word, surprise maybe at how difficult the pandemic was, with his role there and everything else. I think it was challenging in ways that I think was unexpected for many of us who have known him for a long, long time. And that said, I think it just goes to emphasize what you were just saying. I think it's important for all of us, wherever we are in our career paths, to learn how to do this better and to learn from the folks who are doing it well. So would, for instance, sessions at our professional society meetings about this be one way to go? I think so. I think it's so important. I think the rooms would be packed. I would hope the rooms would be packed. I mean, I think it's just really important that we learn how to do this and learn how to do it effectively so we can connect with whoever it is we're trying to connect with, but in a very respectful, but also humble way. I think that's really, really important. So those are just some of my thoughts.
And they're great thoughts. And I think I'm so glad that you talked about humility because it's very clear that that is a very useful and valuable and honest response. And I don't think that as a whole that we have always shown as much humility as we should. So I'm glad you brought that up. So I want to turn a little bit and talk about measles. And we all know measles was declared eliminated in the United States in 2000. So, but as a result of declining immunization rates, spread of measles in other countries, which plays a role in this too. People are traveling internationally and coming back. There have been 1,356 cases of measles in 2005. There have been 3 fatalities. And of those, 92% were unvaccinated or their vaccination status was unknown. And certainly closer to home where I live in Texas, more than half the confirmed measles cases have occurred in West Texas, as we know. And just a couple of numbers on that to put in perspective, 99 of those people were hospitalized. There have been 2 deaths, and they were both in young school-age girls. The children were not vaccinated. They had no known underlying conditions. And this is an interesting little side note. Social media reported incorrectly that one of the girls died from complications of mononucleosis and tonsillitis. And the Lubbock hospital where she was treated made a public announcement, a public statement that said, in fact, she did succumb to complications of the measles. So they set the record straight. And also of interest, the same hospital where these girls were treated at least 10 children for vitamin A toxicity from the unproven and dangerous treatment for measles. So it's real, it's now. And the other thing, and I think it's easy to not really think about this because it seems so part of our lives, is in the past year, 770,000 Americans were hospitalized with influenza. So more than 750,000 people were hospitalized with influenza. 56,000 of those were children. 250 children that we know of died from influenza, 80% of whom were unvaccinated. So we have outbreaks, we have pandemics, but we also have this sort of indolent every winter type thing that we know is going to recur as influenza. So this leads me to this question. So a recent Quinnipiac, which university asked a panel of American adults this question: in thinking about how you decide whether or not to get vaccines for yourself or your family, who would you trust more for guidance? And there's 4 possible answers.
Yeah.
Your doctor,
Yeah.
the Centers for Disease Control and Prevention, Secretary Robert F. Kennedy Jr., or yourself. And so overall, 44% said their doctor, which, okay, we'll look on the bright side, that's close to half. 21% said the CDC, okay, that's good. 5% said Secretary Kennedy, and 28% said themselves. So I think the 28% really reflect what we've been discussing, and that is the democratization of information online. And you and I know, agree on this, and we've talked about this. We need to learn to meet people where they are, meet them in the middle, and go for there. And I think, expertise matters. Of course it matters, but building trust is often more about how we treat people. And I think Reed Tuckson, who we both know, a very influential internal medicine physician who's now focused his work on restoring trust in healthcare, said that people don't really come to their doctor for information. They come to their doctor for guidance. And I think that is more true now than it's ever been before. So what are the most effective ways to reach people that are vaccine hesitant or resistant in our clinical practices? And again, given the constraints of what we talked about earlier with primary care, that's a tough one.
Sue, another $1 million question, and yeah, not easy, not necessarily easy to answer. It's very nuanced, and there's a lot packed in there. The primary thing that comes to my mind at the moment as we're talking about this and reflecting on this, during the pandemic, I remember that Kimberly Manning, the internal medicine physician at Emory in Atlanta, had written a piece, and she also had some posts on Twitter and social media and other places, I believe, just about this very issue about meeting patients where they were. And as I recall, I remember seeing photographs of their lobby at Emory saying, something like, "Are you vaccine deliberating? If so, this is where you want to come. Come and share your questions, and there'll be someone here who can talk with you and help to address whatever questions you may have or address whatever concerns you may have." And I thought that was such a beautiful phrase, that people aren't necessarily, totally against the vaccine or whatever the issue is, but they're deliberating about this. And I think it's important for us to recognize that, especially when we're in the exam room with a patient who may be in that place, to recognize it and try to get at the why. Like, why do you have this question? Why are you thinking XYZ or whatever it is, but to really work hard for us to dig deep within ourselves, to work hard to connect with those patients who may be in that space. Because in many ways, until we understand the why, we probably won't get very far. And that's where I think that element of curiosity and compassion, it comes together, so we can just better meet our patients' needs and really connect with them. If we don't do that, we run the risk of all the, things that we've talked about, which aren't good. I mean, like having no humility and just thinking, no, you need to do this and making assumptions about why. And that's not what, those moments call for. Again, I think it's really meeting our patients where they're at, seeking to understand their why, and then engaging with them at that level and see where it takes you. That's part of the joy of medicine, I think, right? Where we don't know where this is all going, and that's okay as long as we adhere to our principles of good care. Well, not only good care, excellent care, serving the patient, humility, and there we are. We'll end up in a good place, and that's a good thing. So,
I think you said that so well, and I love your approach. And I've thought about this, and it occurs to me that there seem to be a lot of similarities between vaccine uptake and smoking cessation.
yeah,
Think about, and there are parallels in the sense that someone who's a smoker comes to the office, and part of our counsel to them is, yeah, have you thought about smoking? It's almost never going to happen the first time where they say, doc, you're right, I'm going to quit today.
that's so
It's
true. Yeah,
right. It's
yeah,
it's an iterative, if you will, process of,
yeah,
and you've expressed this to me before. It's like, okay, where are we today? Have you thought about this? Not pushy and not, authoritarian, but just,
yeah,
and I think the message there, Janet, is I care, right? I
yeah,
care about you. And
yeah,
um, some people, the message may never get, they may never change their behavior, but others will. And I feel like there's a lot of similarities. And the other thing, and I'm not sure I've seen this written down anywhere, but you and I are old enough. I'm older than you, but you and I are old enough to have seen in the ravages of infectious disease pre-COVID. Obviously, I mean, I remember so well as a 5, 6 year old kid in Dallas, lining up excitedly with my family to get my sugar cube, my polio vaccine, and
yeah, yeah,
because we knew the ravages of polio, and we knew,
that's
and we were excited that there was going to be a prevention for it. So I think so what I'm saying that because I think as clinicians, and you've seen, you talked about your experience with patients living with HIV and AIDS and other tuberculosis and other malaria, you name it. We see what
right.
vaccine preventable diseases can do, and I think to me, I think that's part of our zeal. I really do. I think that's part of our zeal. And sometimes we have to kind of stop and say, okay, step back. Yes,
Yeah.
we've seen this, but that's not going to be the winning argument, if you will. I don't know but those are some of my thoughts. All right. Um,
I agree.
Go ahead.
So I agree with you. I agree with you. In some ways, it's almost like we have special vision in a way where we can see what's coming. And not always, of course. And for an individual patient, things may be much more unpredictable. But the fact is, we know if there's someone who's vulnerable to measles, say they haven't been vaccinated, and they're exposed to measles, there's a very high likelihood that they will get infected. And we know that. We've seen that. We've learned that in medical school, residency over and over again. And so you're right. That does motivate us to have that zeal, if you will, motivates us to try to get the message out in an effective way. At the same time, we have to make sure that we're connecting in a way that's effective and compassionate. So,
Right.
yeah.
Exactly. Um, well, we've talked a lot. I think we've hit a lot of important points, and I'm feeling hopeful. And even though the world around us does not always seem hopeful, I feel like we can leverage, and we do leverage every day, our special relationship, our is
Yeah.
I like to call the secret sauce of primary care, which is our relationship with our patients and the trust. And I think today we've really highlighted a number of ways. They're not anything technical. They're not anything, particularly sophisticated. They're really human factors
Yeah.
that we can leverage to really get our patients. And again, our motivation to do this is to keep people healthy. That's our motivation, and to prevent disease. And so, any closing thoughts you'd like to share?
Oh, thank you, Sue. I agree. We've touched on a lot of important questions today, and the all the information you shared, Sue, is so important and so important to this discussion and these issues. Thank you for doing that. I think that one thing that comes to mind is actually from Paul Farmer. Just thinking, all right, well, did Paul Farmer say anything about trust? And it turns out he did. And his comment, or the quote that's often attributed to him about trust, was trust is built one patient at a time. Oh, that's so interesting. I mean, it's helpful to us being in the exam room with patients, and that's a great reminder. And what's so interesting with that? Well, Paul Farmer being one of the founders of Partners in Health, this global humanitarian organization now to treat disease and very difficult to treat diseases in difficult, challenging places, under-resourced places. That was his comment about trust. And I just thought that was so interesting because here's someone who did that big organizational stuff and clearly had to communicate well publicly and all that, but he landed back with the patient. And that I think is just a good reminder for all of us of where we need to be.
I don't think we could sum it up any better than that. Janet, thank you so much. Thank you
Oh,
for your generosity and for your wisdom and your insights. And we really appreciated our conversation. Thank you all, and we'll see you next time.
thank you
Thanks.
so much, Sue. Thank you. Wonderful to see you. Thank you.